Good morning, everyone, and a very warm welcome to our final day of CRAN's My Colorectal Cancer Coach Summit 2026. We are absolutely thrilled to have you with us again today, and we do hope that you found the summit both informative and engaging. My name is Christopher Mamalidi, and I am the National Patient Programs Manager here at CRAN, the Colorectal Cancer Resource and Action Network, and as well, I am a three-time early age onset survivor. This morning, I am joined by CRAN's eternal motivation, energy, and ever dedicated President and CEO, Filomena Servideo Italiano, who I would love to turn it over to welcome our coaches and viewers on this beautiful Friday morning.
Thanks very much, Christopher. Good morning, my friends, and welcome to the last day of my Colorectal Cancer Summit. It has been a wonderful week, a truly inspirational and exhilarating 4 days of expert led, content rich, evidence based sessions, enriching our understanding of the management of colorectal cancer across the continuum of care. Throughout this week, our colorectal cancer coaches have been diligently training, meeting the prerequisites of the My Colorectal Cancer Coach training and certification program so they can address colorectal cancer queries with ease and comfort from across Canada. And at the same time, you, our live viewers from our colorectal cancer community, have been able to benefit from the depth and content provided directly from our stellar experts participating in the summit. We are grateful for your participation during this Colorectal Cancer Awareness Month. Today's phenomenal sessions will focus on liver transplant, on the management of colorectal cancer metastases, the surveillance phase, post-treatment, thriving in survivorship as you approach beyond cancer, and the importance of exercise during the cancer journey. These are topics that we believe are pertinent to the patient and their caregiver. So as we conclude the week's summit today, please do enjoy these last sessions, which will conclude today at 2:15. Back to you, Chris.
Thank you so much, Filomena. And to start this morning, we will do just our very quick housekeeping notes. To note, the summit is being recorded. Viewers cannot be seen or heard, so there's no need to worry about your mic or your camera. All registrants will receive exclusive early access to the recordings before they become publicly available. To view today's agenda, click on, and I'll click here, the Sessions tab at the top right-hand corner of your browser. Across the top navigation bar, users can also learn about our expert speakers, visit our sponsored web pages, and see bookmark sessions within their personal itinerary. Please leave the lobby open in your browser during the summit. When each summit ends, you'll be prompted to rate the session, and then you will need to return to the lobby to join the next session that is of interest to you. Should you experience any technical difficulties at all, our team are ready to support you. Please just simply reach out to our communications manager, Alyssa Salmon, should you require any assistance at all. Very quickly, and as always, it's important to understand the motivations of our organization and our team. For the new participants joining us this morning, I'll briefly introduce our organization, the Colorectal Cancer Resource and Action Network, or simply known as CRAN, originated as a grassroots colorectal cancer information and support group back in August of 2006, 1 month after the passing of Philomena's father, who was afflicted with widespread metastatic disease. Today, CRAN has proudly become a national, not-for-profit, patient-focused organization, and we're governed by an experienced board of directors. We're counseled by an expert medical and scientific advisory board, of which many members have generously participated in this event. At CRAN, we have two patient advisory councils, one of which is dedicated to the under 50 patient population whose past experiences with the disease actually help to inform our program development. And this is done to ensure our services are relevant and meaningful. In terms of mandate, we champion the health and well-being of Canadians touched by colorectal cancer and others at risk of developing the disease. And we do this by providing three major pillars: support, education, and advocacy to both patients and their caregivers. And this is intended to help a patient's quality of life and as well to assist with their longevity. CREN has expanded its patient-focused mandate to serve multiple tumor type patients through our HTA patient evidence submissions, educational events just like today, advocacy initiatives, and some of our patient programming to ultimately reduce the burden of cancer in Canada. This is our mission. As always, we like to share and celebrate our cancer coaches, and I would like to take the opportunity right now to again highlight them. Our dedicated, and I mean extremely dedicated cancer coaches. I get to see it firsthand, are ready to guide you as you live with or beyond cancer, and we will offer compassionate support and evidence-based information. If you'd like to connect with your own cancer coach, please do just simply reach out to myself or any of our team members, and we will be happy to navigate you. Today, as Philomena touched on a little bit, I'll go into a little more detail on our agenda. We are starting with the presentation of Dr. Anand Ghanekar on liver transplant in the management of colorectal liver metastases, followed by surveillance post-treatment, what to expect by Dr. Carlos Carmona. We will then have a short break to reset before heading to our midday session on life beyond cancer, thriving in survivorship by Dr. Stuart Peacock. Following this, Dr. Scott Adams will walk us through the role of exercise therapy in the cancer journey. Please do get comfortable with your pens, your papers, tablets, laptops, whatever your preference is. Following each presentation, our cancer coaches will enter a 15-minute closed and interactive discussion with our experts so we can ensure adequate knowledge translation and content acumen. During these gaps in the schedule, we encourage our viewers at home to take an additional 15-minute movement break or maybe just grab a snack. And without further ado, we move on with our regular programming. So our first session today at 9:45 is liver transplant in the management of colorectal liver metastases. And this is with Dr. Anand Ghanekar. And we appreciate you very much being here with us today, Dr. Ghanekar. Dr. Ghanekar is an associate professor of surgery at the University of Toronto. He specializes in biliary, I apologize for that pronunciation, and abdominal organ transplant surgery at the Toronto General Hospital, University Health Network. He has been involved in developing and expanding the role of liver transplantation in the management of unresectable liver metastases from colorectal cancer. We are absolutely thrilled to have you here today, Dr. Ghanekar, and I am thrilled to pass you the floor. Thank you.
That's great. Well, thanks for that kind introduction. Are you able to hear me okay?
Yes, we can.
All right, and I'm just going to share my screen here. Sorry, 1 second. All right, are you able to see the slides? Okay, that's great. So good morning, everybody. It's really an honor for me to be here, and thanks for the opportunity to discuss the role of liver transplantation in the management of liver metastases from colorectal cancer. There have been some really important and exciting developments in this field in the last few years, and so I'm really enthusiastic to be able to join you and share those with you. I think you've had a lot of talks. You know, I was looking at the agenda of the meeting over the last few days, and there have certainly been some excellent presenters who have talked about a variety of issues in the management of colorectal cancer, and I'm not going to rehash those. But just to set the stage for this discussion about transplantation, this is some old data from the American Cancer Society, but the proportions are similar in Canada. And so, as you're all aware, about 50% of people with colorectal cancer do develop liver metastases, and about half present with liver metastases at the time of initial diagnosis, and about half develop them later. And of those who have liver metastases at the time of presentation, about half have metastatic disease that's only present in the liver. And about half of those patients are eligible for some sort of surgical therapy. So we're talking about a relatively small proportion of people with colorectal cancer, but a very important population. So, not to rehash what you've heard before, but again, it's clear from decades of experience that surgical resection of liver metastases provides the highest chance of cure. The problem with this is that only a minority of patients are actually eligible or suitable for an upfront liver resection due to the burden of their liver metastases. And so many patients remain unresectable despite attempts to downstage the disease with chemotherapy or other therapies. And, while surgical resection provides the highest chance of cure, the median overall survival in resectable patients is about 5 years. There's a number of studies, which have looked at this, and the 5-year overall survival range is somewhere between, 40 to 70%, depending on which study and which protocol was used. I want to spend a couple of minutes on this concept of resectability, because this is an important issue when it comes to determining whether a transplant is something that should be considered. And so there's many factors that determine resectability in general. And the first is medical factors. So just the general concept of fitness for surgery. Somebody may have serious other medical problems, which may prevent them from having any type of surgery. And so they would be unresectable on that basis. The other concept is oncological resectability. And so the general idea here is that, the disease, should it be resected, there may be reasons not to do a liver resection for colorectal metastases. For example, we tend to do surgery for this condition if it will be curative in nature. And so if there are metastases elsewhere in the body, then we wouldn't consider a liver resection, in many circumstances, but it's not always the case. Response to chemotherapy, genetic factors, these are all taken into consideration and when deciding whether it's appropriate to do a resection. But the main issue is technical resectability, and this is really in the rest of the talk and in most of the literature around resectable or unresectable liver metastases. What people are referring to is technical resectability, and this is the ability to actually do the surgery to achieve a complete removal of the liver metastases. So just keep that in mind as we go forward. That's what I'll be talking about when I talk about resectability, or I'm referring to the technical resectability of the tumor. So technical resectability refers purely to the ability to safely conduct the surgical procedure or procedures that would remove all metastatic disease from the liver while leaving a patient with enough liver for them to survive. And essentially, it's only limited by the future predicted liver remnant. And typically, we need to leave a patient with a minimum of 2 contiguous segments of the liver. And this diagram here shows the anatomic segmentation of the liver that we think about as surgeons in terms of deciding whether something is resectable or not. And if so the 2 remaining segments of the liver need to have enough or adequate vascular inflow and outflow and adequate drainage of bile. And if that can't be achieved by a single operation, then a combination of procedures might be necessary. And if that's not possible, then we consider the disease to be unresectable. And it's important to remember, and this comes up in many of my conversations with patients with colorectal liver metastases, that this concept of technical resectability is dynamic. It can be influenced by the response of the disease to treatments. So metastases that might be unresectable at one time point may evolve to become resectable at a different time point following treatment. Similarly, it's important to remember that technically resectable disease may evolve to become unresectable if there is evidence of disease progression. So what's the current treatment of unresectable, and again, technically unresectable colorectal liver metastases? So the current standard, as you've heard in previous talks, would be systemic chemotherapy, usually involving a regimen such as FOLFOX or FOLFIRI, in combination with a targeted therapy such as bevacizumab or panitumumab. Those would be the most common approaches. And these types of chemotherapy regimens are now achieving median survivals of about 25 to 30 months. And the best results in patients that can be downstaged, so these are patients who have initially unresectable disease, they're given systemic therapy, and then the disease regresses to the point where a resection can be considered. In those patients, the 5-year survival is about 35 to 50%. But the 5-year survival of people who have liver-only colorectal liver metastases on chemotherapy who never achieve a status where they could be resected, the survival in those patients is approximately 10%. So this is the target where liver transplantation has been considered to potentially have a major impact. So just so we're all on the same page, what is liver transplantation? So a liver transplant is a replacement of the entire liver with a healthy liver from either a deceased donor or a living donor. And liver transplantation really has evolved to become the treatment of choice for liver failure, as well as some primary liver tumors, which are confined to the liver, which cannot be resected. And anybody who's being considered for a liver transplant needs to undergo a very rigorous medical as well as psychosocial evaluation to determine their suitability for transplantation. So physically, they must be fit enough for the surgery, which is a very major surgery. They must be fit enough for the surgery, the recovery, and they must be able to take lifelong immunosuppression, which is required to prevent rejection of the new liver. And when I say they must be able to take lifelong immunosuppression, the reason that's an important consideration is because immunosuppression has some serious long-term risks. And so some people, due to medical conditions, may not be able to take immunosuppression. The main two reasons that we would not consider giving somebody immunosuppression is if they had any infections outside the liver, because immunosuppression weakens the immune system. If somebody had some kind of serious chronic infection or acute infection outside the liver, which wouldn't be removed with the transplant, they would be very vulnerable to further complications from those infections. The other would be if somebody had evidence of cancer outside the liver. And the reason that's important is because your immune system is important in controlling cancer. And we know that if somebody has cancer and is treated with immunosuppression, their cancer can progress very rapidly. And if we can't stop the immunosuppression, which would be the situation in the case of having done an organ transplant, like a liver transplant, a life-sustaining transplant, then we have very limited means to treat cancer when somebody is on immunosuppression. So transplantation historically has really been restricted in situations of tumors that are not developing within the liver and that which would be treated completely by a liver transplant. So people with cancers outside the liver, elsewhere in the body, either primary or metastatic, have typically not been considered candidates for liver transplantation, even if they have other, I'm not just colorectal liver metastases. So some other important issues about liver transplantation. So as many of you are probably aware, there's the demand for organs for transplantation far exceeds the supply. And this is across the board, whether it's kidneys, hearts, lungs, pancreas transplants, for example. And so just this is Canadian data from a couple of years ago. In 2024, there were 655 liver transplants done in Canada. But at the end of the calendar year, there were still 609 people on waiting lists across the country for liver transplantation. And during 2024, almost 90 people died while waiting for a liver transplant. So there's a real shortage of organs. Deceased donor organs, which is the most common type of transplant, deceased donor organs are allocated based on, at least in the case of the liver, based on somebody's risk of death without receiving the transplant. So it's the organs are allocated based on medical urgency. And waiting list mortality, as I mentioned, is a significant problem. And so because of all these, this shortage in organs, the transplant community has kind of come up with very stringent criteria as to who should be eligible. And it mainly hinges on what is the projected post-transplant survival. So this precious resource of transplantable organs is kind of allocated to people who are predicted to have a good post-transplant survival, and kind of the bar that is set is a minimum of about 50% chance of surviving for at least 5 years after the transplant. Just to give you an idea, this is the adult liver transplant waiting list at the University Health Network. This was in 2025. So at that point in time, there were 216 people waiting for a liver transplant. And they're for a variety of indications. The most common is actually fatty liver disease these days, which may be reflecting some other trends in our population in terms of the obesity epidemic. Alcohol misuse in very carefully selected patients is the other common indication these days for liver transplantation. And those two account together for about 50% of our waiting list. The other 50% is mostly people with autoimmune liver diseases, such as primary sclerosing cholangitis, primary biliary cirrhosis, autoimmune hepatitis, and those with viral hepatitis, like hepatitis B primarily. As many of you know, hepatitis C has essentially been cured with new antiviral drugs. And so that used to be over 50% of the waiting list for liver transplants, but has now fallen quite significantly to less than 5%. So it's really quite a long list of different diseases that people are having who are on the liver transplant waiting list. So what about liver transplantation for unresectable colorectal liver metastases? Well, this was tried in the past, but the results were quite poor. And this is a graph from the European Liver Transplantation Registry, which showed that in the early 90s, when this was tried, the 5-year survival was about 18%. And so because of these poor results, liver transplantation for this reason was actually contraindicated in most centers around the world until recently. And I'll show you what data has changed the landscape. So why is there a new era in transplant oncology? And this is not just with colorectal liver metastases, but transplantation for other types of liver cancer has had a bit of a renaissance in the last few years. And why is this? Well, liver transplantation as a field is relatively young, with liver transplantation only becoming a common treatment in the 1990s and late 1980s. And the numbers have steadily increased. And with that, the surgical and perioperative outcomes have really, really improved. So nowadays, the chance of surviving a liver transplant is well over 95%. And the chance of surviving 1 year after a liver transplant is over 90%. And so there's more enthusiasm for looking at other indications. The donor pool has been increased by lots of innovations in organ donation. So the types of deceased donors that we now consider are quite different than we would have considered, say, 20 years ago because of innovations in organ preservation. Also surgical techniques which allow us to split deceased donor livers to allocate one liver to more than one recipient have increased the numbers of transplants. And then, of course, as I'll touch on later, living donor liver transplantation has really evolved into a mainstream treatment over the last 20 to 25 years and is a very important part of our program in Toronto. There have been also advances in how to manage immunosuppression in cancer patients so that we don't see many of the complications that we were seeing in the past. And there have been many improvements, as I'm sure you've heard earlier this week, in the systemic therapies that are available for people with abdominal cancers or liver, either primary or secondary liver tumors. So overall, the prognosis of these patients has improved over time. And so more aggressive and innovative forms of therapy are being considered. And as I already touched on recently, the impact of direct-acting antiviral drugs on the issue of hepatitis C has really been a bit of a game changer in terms of changing the makeup of our waiting list. So, suddenly a huge number of people who used to require liver transplants no longer do. And in addition to this, we are now, because of these drugs, able to transplant organs from people with hepatitis C into people who don't have hepatitis C because we can cure the hepatitis C infection following the transplant. And this has led to, in combination with the opioid epidemic, in which many organ donors who have died from opioid overdoses may actually also be hepatitis C positive due to contracting hepatitis C from drug use. Those organs can be transplanted, and a bit of a silver lining in that terrible story. I wanted to show you this just to show what are our outcomes of liver transplantation at the Ejmera Transplant Center here at UHN. And this is data from 2000 to 2021. And as I was mentioning before, the 1 year survival after a deceased donor liver transplant is about 91%. And the 1 year survival after a living donor liver transplant is even better at about 94%. And that difference in between living and deceased donor transplantation is sustained out to 10 years, where the survivals are about 75 and almost 70%. And these data have continued to improve over time. So let's talk specifically about liver transplantation for unresectable colorectal liver metastases. And this was really re-examined, and this is most of the data I'll show you has come from the group in Oslo, Norway. And they re-examined this beginning in the early 2000s. And publication of this seminal paper really reopened the discussion about considering transplantation for unresectable colorectal liver metastases. And one of the main reasons they were able to do this in Norway is because they had a surplus of organs. They had more organs available than they had people on their waiting lists. And so they were able to look at using deceased donor organs in people who weren't traditionally considered candidates for a liver transplant. In this first study they did, their inclusion criteria were fairly liberal. Briefly, what they did is they listed 25 patients for liver transplant who had colorectal liver metastases that couldn't be resected, and out of those, 21 underwent a liver transplant. And after a median follow-up time of about 27 months, none of the patients were actually disease-free, as you can see from the kind of curve on the left side of that graph. So everybody did develop recurrence of the disease after the transplants, but the disease-free survival was actually quite interesting. Sorry, the overall survival was actually quite interesting. At 1 year, the overall survival was 95%. At 3 years, 68%. And at 5 years, the overall survival was 60%. And this was far superior to what we would see as the overall survival in people who would have just remained on chemotherapy, which would have been the alternative. So this was kind of a whet people's appetite for, maybe in the modern era, liver transplant can play a role in improving the survival of people with unresectable colorectal liver metastases. Based on their further analysis of their own data, they came up with some predictive factors for poor prognosis, and they developed what they called the Oslo score. And they really looked at 4 characteristics, and these were the maximum tumor diameter. And most people have multiple tumors, but they looked at what's the maximal diameter of the biggest tumor. And they said if it's over 5.5 centimeters, that gives you 1 point. And the higher the score, the worse the prognosis. The CEA level, carcinoembryonic antigen level, if it was high before the transplant, that also was a bad thing. Progression of disease while on chemotherapy was seen to be a negative predictive factor. And a short time interval between the time of disease diagnosis and the time of the transplant was also a poor prognostic factor. And this gets to the idea of the stability of the disease over time and this ability to select disease that's biologically a bit more favorable. So in other words, people with multiple smaller tumors, low CEA, disease regression or stability on chemotherapy, and people who have stable or regressing disease over a long period of time before the transplant seemed to do the best. So they went on to do, they went on to publish some other papers, and they showed in this paper that the overall survival achieved by liver transplantation was significantly better than chemotherapy, which wasn't shown on the graph in the previous slide. It just shows the comparison between liver transplant and chemotherapy. And but the progression-free survival, as shown on the right side here, was actually pretty similar in patients who had a transplant compared to those who remained on chemotherapy. So why would this be? Well, it's most likely because those who had disease progression after a liver transplant had a pattern of disease that could be then amenable to further treatment. In other words, if they had lung metastases, they could be resected. If they had another liver recurrence, that could be resected. So doing the liver transplant kind of reset the clock and allowed them, even if they developed recurrent disease, to have other options that extended their overall survival. The pattern of recurrence seen in the Oslo patients was predominantly lung metastases in the majority, and then a variety of others, including lymph node, liver and lung, liver, and the primary tumor in the colon, which was rare. So the Oslo group was also able to show that in 19 patients who developed recurrence after a liver transplant, this graph shows what was their survival after their recurrence. And it shows that getting more along the lines of what I was saying just a minute ago, is that even after recurrence, there was more than 50% 5-year survival in those who had had a transplant. So what were the weaknesses of this initial Oslo trial? It was a unique scenario. There was no waiting time in Oslo for a liver transplant because they had more donors than recipients. And so there wasn't really time to to plan the chemotherapy. In other words, when you have a deceased donor liver transplant, you don't know when it's going to become available. So you can't really structure, a course of chemo. Of course, chemo needs to be held for several weeks before a transplant is given. So there wasn't much control over the process in this initial Oslo trial. The chemotherapy was not standardized, and the trial initially included people who had progressive disease. So this was some 10-year data from that initial trial, and this is actually now already a couple of years old. But basically, it did show that even at 10 years, there was a 50% overall survival. So they went on to do another trial after learning from the first one, and they used much more stringent criteria in selecting patients, and they restricted the amount of tumor in the liver, or the largest size of the tumor. They required a response to chemotherapy. The duration of chemotherapy prior to transplant needed to be several months, and there was a minimum interval between resection of the primary colon tumor and the time the transplant was done. And with this approach, they transplanted 15 patients, and they were able to show a much better result with 83% overall survival at 5 years, although the disease-free survival, as shown in this graph, was again much lower than the overall survival. And the 4-year survival after post-transplant recurrence in this group was still high at 72%. They recently published their long-term outcomes of all the patients transplanted for colorectal liver metastases, and once again, they showed that the median overall survival, and as you can see, this is going over many, many years, was well over 5 years. This is really the key point in terms of what they have been able to teach us, is when they looked at the outcomes stratified by their Oslo score, it's clear that those with the lower score, Oslo score 0 to 2, had much better overall survival than the ones with a higher Oslo score. And the median overall survival was over 90 months in people with an Oslo score between 0 to 2. And as I'll get to later, these are the group of patients that we're now focusing on for transplantation. So one question that comes up quite a bit when I talk to patients with colorectal liver metastases is it possible to get a transplant if the disease is progressing on chemotherapy? And the answer is no, and this is the reason. So the Oslo group also shared their experience of how did people with progressive disease do, and as you can see, the disease, none had, disease-free survival over 1 year with a liver transplant that was done when they had progressive disease, and the overall survival was below 50% at 5 years. So Oslo has contributed a lot to this field. The other landmark study, which was just published in 2024 in The Lancet, is this one, which is the Transplant trial. And this was a multi-center, open-label, prospective, randomized controlled trial. So a really well-designed study. And this included about 80 patients and involved 20 centers in Europe. So finally, we got some data that was from outside of Norway and involved a lot of other centers. And what they did is they compared the outcomes of liver transplantation with patients who had similar disease but just remained on chemotherapy, and it was randomized. And the main finding of this study and why it was published in The Lancet is because their findings were similar to the results from the Oslo group, in that, as shown in the bottom left, the overall survival, and this is an intention to treat analysis. So the overall survival of people who received a liver transplant was far superior to those who remained on chemotherapy. On the right side of the graph, that's the actual, if you looked at just the people who, so the left side is the intention to treat. If you look at the people who actually received the protocol, the treatment protocol, because some people did drop out, that was about 38 in each group. And you can see that the overall survival at the top on the right side in people who received a liver transplant who made it through the protocol was over 70% versus 10% for chemotherapy. Just like in the Oslo group, as shown in the bottom right, the progression-free survival was lower with transplant than the overall survival. Again, getting to the point that although people who receive a transplant, many do develop recurrence. It's about 40% at 5 years. The overall survival is still improved because other options are still available. So taking all of this data into account, this is kind of the framework, and I've adapted this a little bit. This is kind of the framework that we're now using to manage colorectal liver metastases. And in the past, so you can see that, I'm not going to spend a lot of time going through all of it, but basically the focus, which is the kind of left 80% of the picture, is on resection, is on surgical resection, either by giving chemotherapy to shrink things, using combinations of treatment to grow the side of the liver that's going to stay in, using two-stage hepatectomy. So there's lots of options for resection. But in those patients who, if you follow the chain down the right side of the chart here, people who are unresectable, technically unresectable, who respond to chemotherapy, who still remain unresectable based on even by more aggressive techniques such as two-stage hepatectomy, who continue to respond and our disease is under control with chemo, they should be now in the modern era evaluated for a liver transplant. So we, led by Dr. Sapasochin, who has now unfortunately moved away from our center back to Spain, he had led us through a protocol to evaluate living donor liver transplantation for colorectal liver metastases. And the main criteria to include patients were, adults between the age of 18 to 68, unresectable liver-only disease, a minimum interval of 6 months between transplant and the time that the primary colon tumor was removed, no evidence of vascular invasion by the tumor, stable disease, as I said, on chemotherapy for at least 6 months, and they had to have a potential living donor available. Who did we exclude in this trial? People with metastatic disease outside of the liver. As I mentioned before, that's an important point. Some genetic, a poor prognostic factor is this BRAF V600E mutation, and those who were progressing on chemotherapy for all the reasons I mentioned. Again, I won't spend a lot of time on this, but basically the idea was that we would see patients if they had, because the standard is in people with synchronous liver metastases and asymptomatic primary tumor, the standard would be to start systemic therapy. If they were responding to systemic therapy, we would be asked, would they be a candidate for a liver transplant? If yes, they would have their colon tumor removed. They would then resume chemotherapy. If they continued to respond and had liver-only metastases that remained unresectable, we would evaluate them for a transplant. If they were considered medically suitable for a transplant, we would evaluate their living donor. And if their donor was found suitable, we would schedule a date for the surgery. Working backwards from that, we would do a PET scan approximately a month after stopping chemotherapy to make sure there was no extrahepatic disease. And then we would do a staging laparotomy where we would sample the lymph nodes from around the liver, make sure there was no occult metastases there. And if all that was negative, we would, within a week, move towards move to doing the living donor liver transplant. So under this protocol, we did 22 transplants between 2019 and 2025. It's important to note that even though many had a very good radiologic response to their chemotherapy, all had viable disease in the liver when we removed it. So the other issue is that many of these patients had some kind of other treatment before the transplant. 7 had a hepatic artery infusion pump in place when we did the transplant. 7 had had liver resections or ablations or some combination of that before we did the transplant. And of the 22, which we are continuing to follow, 6 have developed recurrence, but only 3 have passed on out of those 22 patients. And 1 death, unfortunately, was unrelated to cancer. 2 patients have died as a result of recurrent disease. So our results, at least the preliminary results, are similar to what other jurisdictions have been seeing. We published some of this data along with a group in the US who's also been doing living donor liver transplants for this indication, and so this data is publicly available. So what about what's going on now? And so this is where the real kind of major developments have happened. So based on our protocol here in Toronto, and with growing worldwide experience with liver transplantation in general for unresectable colorectal liver metastases, many provinces in Canada now are offering deceased donor liver transplantation for unresectable colorectal liver metastases as a standard of care treatment. So it is no longer investigational protocol as it had been for many years. As of last fall, in Ontario, we performed our first deceased donor liver transplant for somebody with unresectable colorectal liver metastases. I can't speak for the protocols that are in place in other provinces in Canada, but in Ontario, the Trillium Gift of Life Network basically adopted the same protocol that we were using for living donor liver transplantation in terms of the inclusion and exclusion criteria, in terms of the, as I went over the need for response to chemotherapy, a minimum interval between the time of the initial resection and the transplant, etc. The challenge with deceased donor I should mention that because deceased donor organs are a provincial resource, before people can be put on the waiting list with unresectable colorectal metastases, there is a provincial committee of experts, many of whom spoke earlier this week in this meeting, who adjudicate on the suitability of patients for a liver transplant. And we have to present the case, describe all of the features, and again, getting back to the idea that transplantation is a very valuable resource and there's a shortage of organs, this committee has to decide, is the expected prognosis of somebody with liver transplant good enough that it's justified to allocate that resource to them. And so there is an expert committee who adjudicates on each and every candidate at a provincial level. The challenge with a deceased donor liver transplant is we don't know when it's going to happen. We can't predict it the way we can't book the surgery the way that we can with a living donor transplant. So what the province agreed to do is that in people who are candidates, we would stop their chemotherapy, and about 4 to 6 weeks after that, we would, just with the living donor protocol, we would do a PET CT and a staging laparotomy in order to make sure that they were good candidates. Then, with a living donor, we could just do the surgery as booked. So what we have to do with a deceased donor transplant is the province has agreed to give them an extremely high priority on the waiting list in order to try and achieve a deceased donor offer within a couple of weeks, basically, of being put at that high priority level. In Toronto so far, we've done 3 deceased donor liver transplants for unresectable colorectal liver metastases, and we have additional patients on the waiting list. So I'll wrap up there. In summary, basically, liver transplantation for unresectable colorectal liver metastases does improve overall survival in highly selected patients. In Ontario, both living donor and deceased donor transplantation are currently available as standard of care treatment. Prior treatment with surgical resection ablation or even radiation does not preclude future liver transplantation. That's an important question that I often get from patients. If I have a resection, does it mean I can never have a liver transplant? So that's an important point. The other thing is that the worldwide experience is limited, and the criteria to refine patient selection is going to evolve. And there are many trials underway around the world to try and better understand who will do well with a liver transplant. One of the main questions is actually, do we have to wait until somebody has unresectable disease? So one of the questions is, are there patients who would just do better with a transplant up front instead of going through all these other treatments and then only using a transplant as a last resort? Should we consider it earlier in the disease process? So this question hopefully will start to be getting answered in the next few years. So thanks very much for the opportunity to present, and I hope that was useful for you.
That was amazing, Dr. Ghanekar. We appreciate it so much. Your expertise, your time, and your mentorship on such an important treatment option for colorectal cancer patients working through liver metastases. It's truly amazing as well to see the development of liver transplant into a far more viable option, or options, I should say, to be considered by patients. Now, for our silent viewers, you can now head back to the lobby to join the next session at 10:45 Eastern Standard Time with Dr. Carmona on what to expect post-treatment. Our coaches will now head backstage for their first question period of the day. We will see everybody at 10:45.